Beckwith-Wiedemann syndrome is a pretty commonly tested syndrome on the USMLE. It's not very common in clinical practice, but because this is so commonly tested on the USMLE, I encourage you to get to know this one really familiarly. So this is a syndrome that typically presents pretty early on in the newborn period, and the reason is because these children tend to have a neonatal hypoglycemia. And the reason behind this is that early on, during embryonic and fetal development, there is a high level of IGF-2, and that just has to do with the specific mutation that's involved in this syndrome. And so because of that, they tend to develop pancreatic beta cell hypertrophy, and as a result, they have high levels of circulating insulin. So this is associated with ischemia, omphalocele or umbilical hernia, and macroglossia. Although the omphalocele or umbilical hernia doesn't necessarily have to be present, the macroglossia may be very obvious, or it might be more subtle. So this isn't necessarily a very obvious diagnosis right away, but the neonatal hypoglycemia is one of the things that present more uniformly throughout the children who are affected by this syndrome. This was formerly known as EMG syndrome, which stands for oxamphilos, macroglossia, and gigantism. Oxamphilos is just a term for omphalocele, and then macroglossia and gigantism. Now, what you commonly hear about with Beckwith-Wiedemann syndrome is a hemihypertrophy. And when you think of hemihypertrophy, you think, okay, well then one side of the body is going to be larger than the other. And to a certain extent, that may be true, but really what we mean by hemihypertrophy or hemihyperplasia is that there are segmental regions of overgrowth, or just certain parts of the body or select organs can be affected by the overgrowth. So it's more of an asymmetric hypertrophy than anything else. Another one of the issues with this syndrome is that approximately 10% will go on to develop tumors, and these are usually the small round blue cell tumors, most commonly Wilms tumor. Children with Beckwith-Wiedemann syndrome have about a 600 times greater risk of developing Wilms tumor than other children. The estimated incidence of this syndrome is between 1 in 13.7 thousand and 1 in 15,000, so again, relatively rare compared to some other genetic syndromes. So getting down to the genetics of it, this is typically due to a sporadic mutation of the short arm of chromosome 11, and there are a lot of important genes on this chromosome. So the first of which is IGF-2 gene, which codes for IGF-2, insulin growth factor type 2. And this has a growth-promoting insulin-like effect, and this protein is going to be overexpressed in Beckwith-Wiedemann syndrome. Another gene that can be affected and is usually affected in more of the familial cases is P57, and this codes for a protein that inhibits the cell cycle. And so this can play into why there's an overgrowth, but also this is really what's behind these tumors that develop. And you're going to see that you're more with Beckwith-Wiedemann syndrome if it's in the family, if it runs in the family, in the minority of cases that are congenital, they're more likely to develop a tumor than the sporadic cases. There's a few other genes, H19, which codes for RNA, which isn't transcribed or isn't translated into protein, but it is involved in growth and tumor suppression. And then there's a couple other genes that are imprinting centers. So this doesn't have this isn't necessarily a Mendelian like syndrome. This does have some imprinting that's involved, but I really don't want to get too deep into the genetics because I don't expect that you're going to be tested on that. So if there is inheritance, it's usually autosomal dominant with variable penetrance, And like I said, the overgrowth is associated with IGF-2 expression both prenatally and postnatally. The features that we see in Beckwith-Wiedemann syndrome, and I didn't highlight any of these, but early on you'll see that these babies are very large, invariably. So they're large for gestational age. There may be hemihypertrophy or hemihyperplasia. Hemihyperplasia is probably the more accurate word. And then the neonatal hypoglycemia. The craniofacial features include macroglossia. A lot of these babies will have a facial nevus flammeus, and you'll see some of the pictures. You'll see that most of these babies will have them. You can also see linear creases anterior to the ear or posterior auricular pits. Some of these babies will have infraorbital creases as well. Abdominally, you can see an omphalocele or umbilical hernia. You can also see visceromegaly or feel visceromegaly or see it on ultrasound. This can involve the liver, kidney, spleen, and other organs. As far as endocrine features, because this causes beta cell hyperplasia, it leads to a hyperinsulinemic hypoglycemia. So when you're working up the hypoglycemia, you should get an insulin level, and you should see an inappropriately elevated insulin level relative to the glucose level. You can also see, if you look on MRI, you can see enlargement of the adrenal cortex in some cases. And cytomegaly of the adrenal cortex is actually pathognomonic for Beckwith-Wiedemann syndrome. This can cause renal abnormalities and does in many cases. Nephrocalcinosis is one particular renal anomaly. There can also be structure abnormalities as well. And then, as we mentioned, there are tumors that can come out of this, cancerous tumors, and that includes Wilms tumor, hepatoblastoma, neuroblastoma, rhabdomyosarcoma, and then they can also develop adrenocortical carcinoma. Wilms tumor is the most common. Adrenocortical carcinoma would be the least common. So here you can see this child has macroglossia, although it's not as pronounced as you may see in some children, particularly younger children, babies. Here you can see a posterior auricular pit right here. And then this is an umbilical hernia. So again here you see pitting, macroglossia. Here's an omphalocele. You can also see this baby's tongue is protruding as well. This is a severe case of macroglossia. This will require surgery. And I might add that the macroglossia, if it's severe enough, can actually cause airway obstruction, and that's one of the things that we're concerned about, because in and of itself, Beckwith-Wiedemann syndrome is not necessarily deadly unless you develop a tumor, but with the airway obstruction, that can be obviously an emergency. So here's a baby with macroglossia. You can also see that this baby also has a facial nevus flammeus. This baby has a nevus flammeus, macroglossia. Now this young man here has a, that might be a nevus flammeus there, it's hard to tell, but you can see has a slight hemihypertrophy of his face. And this baby, again, macroglossia, and it's hard to tell, baby's turned a little bit. You can see as they get older, the features tend to become a little more or less pronounced. Here's a case of hemihypertrophy, and you can get limb length discrepancies, and in that case, you may need to consult surgery. Again, this child seems to have some hemihypertrophy of the face. As far as development, physically, their growth rate will slow around 7 years of age, and they typically attain normal adult height. Significant hemihypertrophy can necessitate surgery, and then macroglossia can interfere with speech, which can lead to language issues, but that's not due to, in most cases, it's not due to a cognitive issue, it's due to the tongue. And so In these cases, if the tongue is not large enough to where we want to do surgery, but it is large enough to where it interferes with speech, you can set these children up with a speech-language pathologist, and they can usually work around it. Cognitively, if they have severe hypoglycemic episodes, those can cause CNS injury, and that ultimately can cause cognitive issues, permanent cognitive issues. So you may hear Beckwith-Wiedemann syndrome is associated with mental retardation. It's not really necessarily true. A lot of children with Beckwith-Wiedemann syndrome will go on to be cognitively normal. However, if there are these hypoglycemic episodes, or hypoxic episodes, for instance, if there's an airway obstruction and it goes unrecognized and there's hypoxia to the brain, those both can permanently affect cognition, and that can lead to a lower IQ. In general, Beckwith-Wiedemann syndrome is not associated with reduced cognition. Their social development is typically normal, nothing really that is going to affect that. As they get older, the effects become less prominent, and these children will typically go on to become normal functioning adults. For diagnosis, we want to always keep in mind some of the differentials. So anytime you have a child with hypoglycemia, one of the first things, more common things we think of is neonatal hypoglycemia due to maternal diabetes. And so the way you can differentiate this, usually it'll be straightforward on the test, because you can't go too far into step 2 and step 3 question without them giving you some information that's going to help you with your differential. But a careful review of the maternal history, if she has a history of diabetes during pregnancy, then certainly neonatal hypoglycemia due to gestational diabetes is going to be your number one on your differential, because it's so common. These babies will be large for gestational age, but they typically do not have these other stigmata of Beckwith-Wiedemann syndrome, such as macroglossia or omphalocele and umbilical hernia. Costello's syndrome is extremely rare, but I include it here because it's very similar appearing to Beckwith-Wiedemann syndrome early on. Most patients with Costello's, however, are going to have heart abnormalities. You can have that in Beckwith-Wiedemann syndrome, but it's a lot less common. So when we are doing our screening for children that are diagnosed or presumptively diagnosed with Beckwith-Wiedemann syndrome, we always want to look at their heart because Costello's syndrome is a possibility. With Costello's syndrome, they typically have structural or electrical heart abnormalities. Most commonly, if it's structural, it's going to be a hypertrophic cardiomyopathy. They also tend to have a fast-beating heart. These children have a much different prognosis than with Beckwith-Wiedemann. They will tend to have mental retardation. Other features are seen in this syndrome that aren't seen in Beckwith-Wiedemann, and that's going to include loose joints, loose folds of skin on the hands and feet, and coarsened facial features. Soto's syndrome is quite different. You don't have hypoglycemic episodes. Facial features are different. So if you watch the Soto's lecture, you'll see that these children have frontal bossing. Their eyes are usually in a slightly different position. They have an anti-mongoloid slant, which is variable, but the anti-mongoloid slant, that's just a down slanting of the palpebral fissures. And then they also tend to have a pointed chin. Developmental delay will occur in most cases of Soto syndrome, so again, slightly different prognosis. As far as technically making the diagnosis, really the only way you can make the diagnosis definitively is by cytogenetic and molecular genetic testing, but this syndrome is usually presumed clinically. So one of the big clues is the early hypoglycemic episodes in association with overgrowth and the associated stigmata, particularly macroglossia. So you have a child with hypoglycemic episodes and overgrowth. Well, that can be gestational diabetes, a child that's hypoglycemic. But when you see these associated stigmata like the macroglossia or the helical pits or umbilical hernia, then you're thinking Beckwith-Wiedemann syndrome at that point. So there are major criteria and minor criteria that have been described in some literature. these all sort of fall under the features that I talked about earlier. But generally, a lot of practitioners will use this, and if there's 3 major criteria, that's considered a presumptive diagnosis. If there's 2 major criteria and 1 minor criteria, then that's also considered a presumptive diagnosis. This should say mid-face hypoplasia. Okay, so it's generally pretty easy to fulfill this because we're not thinking Beckwith-Wiedemann syndrome unless the child is large for gestational age, and so there's 1 criteria right there, and then the neonatal hypoglycemia, that's going to fulfill 1 minor criteria, and then so all you need to do is have 1 of these other criteria to fulfill these, and you've got a diagnosis. So when you have a baby with hypoglycemia, it's always important to investigate that hypoglycemia because there are a lot of differentials for hypoglycemia, and what we really want to do is make sure, if we're considering Beckwith-Wiedemann syndrome, we want to make sure that we document the hypoglycemia and also that this is indeed a hyperinsulinemic hypoglycemia because there are other causes of hypoglycemia. So when you're doing your differential, one of the first things you think of with hypoglycemia is this an acidosis? Is this caused from lactic acidosis or ketoacidosis? Is that associated with the hypoglycemia? Because there are a lot of inborn metabolic errors that cause hypoglycemia. So you get arterial blood gases and plasma ketones, and what you should have is no acidosis and low plasma ketones, because when you have low blood sugar, you should have low ketones as well. So if the arterial blood gases were to show an acidosis, then that turns our diagnosis away from Beckwith-Wiedemann syndrome and towards a metabolic error. And that could be enzyme deficiencies like glucose 6-phosphatase deficiency, fructose 1,6-diphosphatase deficiency, pyruvate carboxylase deficiency. You can also have ketotic hypoglycemia, a glycogen storage disease, growth hormone deficiency, cortisol deficiency. So those would all be hypoglycemia associated with acidosis. With Beckwith-Wiedemann, it's not associated with acidosis, so your ABG should be normal. As far as these sugar markers, of course, your blood glucose is going to be low. Your plasma ketones are going to be low. Your plasma-free fatty acids should be low. Now, if your plasma-free fatty acids were high in association with a low blood glucose, then you would think of a fatty acid oxidation disorder. Your serum insulin should be high. Remember that we have pancreatic beta cell hyperplasia. The serum IGF should be high, and then the C-peptide should be high. Now, why do we get a C-peptide? It's common practice to get a C-peptide anytime you have a child coming in, or anybody really coming in who has high insulin levels, because we want to know, is this endogenous insulin or is this exogenous insulin? Now, if the child has been in the hospital the whole time, you might be safe getting by without getting a C-peptide level. But if a child is ever brought in and from outside the hospital, has high insulin levels in association with hypoglycemia, you should always get a C-peptide level because you want to know, is this endogenous or exogenous insulin? And Munchausen syndrome by proxy, with mothers injecting their children with insulin, is not terribly uncommon. I mean, it's not particularly common, but it is a possibility that you need to keep in your differential for a child with hypoglycemia. So remember just that the C-peptide is the end, the little tail of insulin, and so anytime you have insulin that's secreted by your body, by your pancreas, it should have the C-peptide to go with it. So that if you have endogenous hyperinsulinemia coming from within your own body, you'll have concordance between your insulin and your C-peptide. Whereas if you were to get insulin injected into you, that doesn't contain the C-peptide, and so your C-peptide will be normal or low relative to your insulin level, which will be high. So all of these together, this will help you determine that this is a hyperinsulinemic, an endogenous hyperinsulinemic hypoglycemia, and that puts Beckwith-Wiedemann syndrome on your radar. So, management for this syndrome is going to involve attending to the immediate concerns first, which is preventing or correcting the hypoglycemic episodes, ensuring that the baby has an adequate airway. And then once that is done, and usually the severe episodes of hypoglycemia should resolve within the first few days of life. There may be hypoglycemic episodes later, but the severe issues with hypoglycemia should not persist beyond the first few days of life. But once that has been addressed and you've got the child stabilized, then after that you'll start surveillance for malignancies. So initial management, we address the airway if necessary and the hypoglycemia. We'll give the baby IV dextrose drip sufficient to maintain a blood glucose of greater than 60 milligrams per deciliter. Frequent feeds are useful because the more often that a baby eats, even if it's just small amounts, it keeps the blood glucose higher than if you were to eat a lot. If you were to have less frequent but more food, that's just going to cause peaks and troughs. So frequent feeds are encouraged. And then if, like I mentioned, the hypoglycemia persists beyond the first few days of life, then you should consult a pediatric endocrinologist. They can use diazoxide, which inhibits insulin, and that's useful for these children. It doesn't directly inhibit insulin, but it inhibits insulin release. Other things you should do: baseline routine labs, abdominal sonography to screen for tumors, get a urinalysis, you're looking for functional kidney issues, EKG and echocardiography, baseline MRI, and alpha-fetoprotein levels. Long term, we do abdominal sonography and serum alpha-fetoprotein levels every 2 to 3 months to screen for hepatoblastoma and other abdominal tumors. You will continue getting sonography every 2 to 3 months until the child's 8 years old. And you'll continue getting serum alpha-fetoprotein levels every 2 to 3 months until the child's 4 years old. You also get frequent growth checks, and you can get a surgical consultation for issues that are secondary to the hemihypertrophy, such as macroglossia or leg length discrepancy, are the more common ones that are going to require surgical management if they're severe enough. Long-term, cancer is the most common, more concerning complication of Beckwith-Wiedemann syndrome, affecting approximately 1 in 10 patients. That risk is higher in cases that are inherited or when there are other family members affected. The hypoglycemic episodes, as mentioned, need to be treated aggressively, as insults can result in permanent brain damage affecting cognition and future well-being. Now, as we said, the hypoglycemic episodes tend to be worse very, very early on in the newborn period, but it's always a concern throughout childhood, and so it's useful to have probably a blood glucometer at home. Make sure that the parent is doing frequent feeds. And then signs and issues related to Beckwith-Wiedemann syndrome will lessen with age, and these children will go on to become fully functioning and healthy adults, provided that there's no significant brain damage from hypoglycemia or hypoxia, and provided that they don't get a really bad cancer.